Hello, Pat. It is my pleasure to be here talking with you about some topics related with myopia prevalence, current trends, potential future implications, as well as the factors that can influence the current situation and what we can do as eye care practitioners using different treatment options and how to implement them in clinical practice. We have evidence that prevalence of high myopia is rising disproportionately, and this might be a serious concern considering the potential implications in vision impairment risk in adulthood and elderly. So this takes me to the first question. Are these estimates based on population studies?
Jose, yes, there's plenty of evidence, a number of published studies from East Asian countries that demonstrate a rising prevalence of high myopia. Taiwan is a good example. In 1988, the prevalence of high myopia in Taiwan was nearly 25%. And by the year 2005, this had risen to nearly 38%, or approximately 1 out of 3 or 4 people are highly myopic. Similarly, if we look at data from Fenghua City in China, the prevalence of high myopia was only 7% at the beginning of 2000, and in just over 15 years, it had doubled to nearly 18%. The point is that we think that the reason for this rising prevalence of high myopia is because children are getting myopic at an earlier age than before. So if you become myopic at, let's say, 5 to 6 years of age, and we have plenty of evidence that shows that younger children progress faster. So you have a child that is myopic at 6 years of age, they're progressing faster, they're going to be in the progression mode much longer, and therefore they're likely to have higher net myopia. And that sort of explains, we think, the rising prevalence of high myopia in East Asian countries. But talking of which, Jose, there's actually not much evidence from other regions or other countries in the world. So do you have any opinion on how we can gather more evidence or try to have an understanding of the rising levels of myopia and high myopia from other parts of the world?
Well, vision care should be in the agendas of states, universities, public and private sectors in general. This has not been the case in many regions, as in Europe. We need to establish research initiatives to conduct ambitious population studies and follow these results on a periodic basis. The potential of information obtained from industry and eye care practitioners to understand the dynamics of prescriptions by eye care practitioners should not be ignored. Even when this data is limited to the person that have a visual examination and a visual problem, it might be relevant to follow trends in prescriptions and evaluate how the magnitude of refractive errors, such as myopia and high myopia, evolve in the population over the years. As said, population studies are urgently needed, but other routes to gather relevant information should also be explored. Such data is critical to develop regional strategies to cope with this rising public health concern. So, Pat, irrespective of the exact numbers, can myopia control have an impact on global visual health?
Yes, Jose, absolutely. And I think one can measure impact in a number of ways. And as optoms, we're all familiar with vision, so we can talk about how myopia has an impact on vision. In a study that we at BHVI conducted along with Professor Ming-Wang He in China, we looked at highly myopic eyes that did not have any ocular pathology. And what we found was that despite not having any ocular pathology, these myopic eyes had reduced vision. And higher the levels of myopia, the vision was lower. So what we're saying is we're thinking about a highly myopic eye. Because they're progressing faster, they have to change the spectacles earlier. The spectacle lenses are more expensive, and our data is showing that in spite of not having any pathology, the vision is not optimal. So all of this is quite a difficult situation for the highly myopic person to deal with. And if we were able to control myopia, even by a small amount, you can see that it would make a significant impact in terms of reducing the burden for that myopic person. Jose, so then there are those eyes that are at risk of developing complications, highly myopic eyes developing risk of complications later in life. So do you think controlling every diopter of myopia has an impact on reducing the risk of these complications?
Well, that is an excellent point. There is some reluctance by some practitioners that this might have an impact on vision in the elderly population. They consider that saving 1 or 2 diopters might not have any implication and any clinical impact, or that such impact can be only confirmed in several decades from the intervention in childhood or youth. However, we do know that myopia incidence, prevalence, and progression is growing faster now. We also need to consider the current evidence that clearly shows a connection between the degree of myopia and axial elongation of the eye and the risk of pathological complications. Though the risk increases more rapidly for higher values of refractive error, even for lower values, the risk increases significantly as well. For example, the risk to have a myopic maculopathy, retinal detachment, or glaucoma is significantly higher for moderate compared to low myopes. Altogether, this suggests that we have a strong basis to start action now, as retarding the interventions will make millions of people to miss the opportunity to have a benefit in their future visual health. So even if we cannot fully understand the benefit on an individual basis, we have a strong evidence that collectively such interventions should have a very positive impact on visual health of the elderly population several decades ahead of us. So Pat, this takes me to another point that might be a doubt for many practitioners. Which kind of myopia to address and when?
That's an interesting question, Jose. And I think I understand the difficulties here. It is felt that there are certain variants to myopia, genetic variants, syndromic associations, or what is loosely called pathological myopia, that people feel might not respond to myopia control treatments as much. But there are certain things that we need to understand here. Firstly, there is not much we know in terms of these genetic variants, whether they are a different category. And secondly, if we look at the data for myopia control treatments, especially the more recent treatments, we can see that these treatments are able to control myopia by more than 50%. In addition, in a study that we conducted at BHVI, we used a myopia control lens in one eye and a single vision lens in the other eye. And what we found was that the myopia control lens was able to slow the progression of myopia in 7 to 8 out of 10 children. So what that is saying is that myopia control treatments are quite effective. So the best approach is to start early and fit them with the appropriate myopia control strategy.
Pat, another relevant point is, what is the latest evidence regarding the role of modifiable habits on myopia onset and progression?
There are, as you know, there are a number of risk factors that we found associated with myopia. For example, sex, parental myopia, urban living, time near work, outdoor time, height, diet, so on and so forth. But of all of these risk factors, only 2 were found to be causally associated with myopia. The first one is education. We saw that education in countries where there is a lot of focus on education, there's more myopia. In societies where there is less focus on education, there's not much myopia. And more recently, what we found was that if you take a group of, let's say, 6-year-old children, and if some of the 6-year-old children are in a lower class and some of them are in a higher class, those in the higher class seem to have more myopia. And that might be related to the amount of work that they do near work and less time outdoors. So education is one factor. The second factor that was found to be causally associated with myopia is outdoor time. What was found was that despite having other risk factors like parental myopia, if you spend more time outdoors, you can try and reduce the risk of onset of myopia. So, education and outdoor time seem to be the most important modifiable factors for myopia.
And also, I would like to ask you, how easy are habits modifiable, how to start, and what to improve?
That's quite a difficult area to address, Jose. As you know, we've just spoken about education and outdoor time being the two modifiable or the two factors that we found to be causally associated with myopia. So, in terms of education, it is quite difficult, obviously, to try and modify the educational system. But what can be effective is to try and delay the onset of schooling. So, even if we are able to delay the onset of schooling by 1 year, we would have gained quite significantly in terms of trying to reduce the burden of myopia. And that can be illustrated with an example. If you take a group of children living in Singapore and a group of children of the same ethnicity living in Australia, and we know that in Singapore they start early, schooling starts as early as 3 years, whereas in Australia schooling starts around 5 to 6 years of age. We find that for the same age, the prevalence of myopia for the same ethnic group is much higher in Singapore than in Australia. And that goes to explaining how we can try and gain or reduce the impact of myopia by delaying the onset of myopia by delaying the schooling. The other modifiable factor is outdoor time. And again, here it's best to start early because you can try and instill those practices in younger children far better than in older children. So, trying to instill those good habits in children as young as 5 or 6 years of age is much better, and again is going to return as a big bang for our buck rather than trying to do it in 12-year-old children. And beyond that, we definitely need the policymakers and the community to get involved to change and understand these systems. So until then, I think the best thing we can do is to try and promote outdoor activity. It has to be as young as possible in younger children. Okay, Jose, we spoke about modifiable risk factors and we found that it's quite a challenging area. On the other hand, we've made great strides in trying to slow the progression of myopia in those that are already myopic. And if we look at what we have achieved over the past 10 to 15 years in terms of, for example, optical strategies, spectacles, contact lenses, and orthokeratology that can slow myopia, it's quite revolutionary. We also have atropine that has been in use for a long time, but of late we have moved to low dose atropine. So it looks like we have plenty to offer. So, Jose, what do you think? Do you think there is a category of patients that that's a priority for these treatments? How would you address this area?
Well, it is a very pertinent question. The quickest answer might be to make myopia control to every myopic kid or adult showing progression. However, as you previously mentioned, the evidence we have today is mainly focused on myopic kids from 8 to 12 years of age with low to moderate myopia up to 5 diopters. So, current evidence-based practice should focus on addressing kids with those characteristics in order to be able to assume that the results of the clinical trials could be extrapolated to myopia control in clinical practice.
So, Jose, what are the variables that you would have to take into account when deciding between these various treatment options?
Well, we do know now that parental myopia, age of onset, progression rate, and environmental factors are related with habits of outdoor activities and near work activities are all relevant for this. Those showing faster progression at any early age, combined with low levels of outdoor activities and high intensity of near work, should be targeted. The different treatment options range from pharmacological interventions to optical interventions using different platforms such as contact lenses or spectacles. Adverse effects or concerns with long-term effects of chronic administrations of pharmaceutical agents or the presence of moderate to high astigmatism might limit the application of some treatments, such as optropine or contact lenses. Compliance with the use of spectacles by some children, either because of aesthetical concerns or incompatibility with some activities, including sports, might limit the efficacy of ophthalmic lens solutions. So the decision has to be made on a patient-to-patient basis, considering the best evidence on the efficacy of treatments and suitability to fully correct vision and maximize the compliance with the treatment application.
Thanks for that, Jose. So what kind of myopia to address and when?
Well, it's an excellent question. Going back to the clinical trials that endorse the use of current treatment options, we are talking about low to moderate myopia in young children showing progression. The start of the treatment should be established as soon as possible in order to maximize the accumulated impact of retention over the maximum time of progression. We do know that the window of opportunity to treat is quite narrow, covering the period of progression. This also varies from patient to patient, but it's quite clear that the faster progression, when the maximum impact can be created, is around the age of onset of myopia and the following 3 to 6 years. So it is critical to start the treatment as soon as possible when myopia shows progression in order to cover the period of maximum and faster progression.
So, Jose, let's talk for the next few minutes on tracking myopia progression in the clinic. As you know, there is a lot that we can offer in terms of myopia control strategies at the moment. We've got spectacles, we've got contact lenses, orthokeratology, and atropine. And just in each of these areas, there's been a lot of progress. Just over the past 2 years, there's been improvements in terms of newer types of contact lenses, newer types of spectacle lenses that offer better myopia control. And when we in the research field, we talk about myopia control, we use phrases such as 55% reduction in spherical equivalent, 50% reduction in axial length, or we talk about metrics such as retinal image quality or visual performance and so on and so forth. So for the average practitioner, this can be quite daunting. Should I measure axial length? Should I measure spherical equivalent? Should I be looking at peripheral refraction? So, Jose, what's your take on what are the minimum requirements or the minimum standards or procedures that a practitioner should start off with to practice myopia control?
Well, this is a very important question for practitioners to implement these treatments. For most of the treatments to be applied, the requirement instrumentation is the basic one existing in any optometric or ophthalmological practice, including instrumentation to assess refraction, accommodation, binocular vision, anterior and posterior segment eye health. The minimum standard equipment should allow the clinician to routinely measure refraction and keratometry, binocular vision and accommodation, and eye health. Having routine data on refraction and keratometry, we can indirectly understand if there are significant changes of axial length, as several studies have shown a strong correlation between changes in refraction and axial elongation during myopia progression. Additionally, a comprehensive examination of accommodation and binocular vision is relevant in the context of myopia progression. Ideally, being able to measure axial length would allow follow-up of the elongation, which is likely to be the critical aspect of myopia progression and the implications for future pathological risks. Some specific treatments, such as orthokeratology, have specific requirements of technology, for example, for corneal topography examination. But another question that usually clinicians pose is, when should myopia control treatments be stopped?
Firstly, I think there is no reason to stop a myopia control treatment because these treatments are optimized to provide good vision. However, there may be some reasons to stop treatment, such as cost, accessibility, visual performance, and so on. So, if a decision has been taken to stop myopia control treatment, then there are certain things that we need to look at and address. The first of these is age. We know that with age, myopia progression slows. So, the older the age, the better. We know that in young adults, myopia progression is minimal. So, you have to try and understand what their progression has been, their age, and see whether it's the right time to stop. The second thing is to look at the stability of refractive error progression. If we want to stop myopia control, we need to be sure that there has been minimal to no change in myopia progression for the past year to year and a half. And then you can transfer them to the appropriate corrective modality that provides them with the right vision. So, with atropine, because we know that there is rebound of myopia with atropine, the approach has been to taper the atropine dose from high doses to lower doses over a certain period of time and then monitor progression. If when the dose is lowered or atropine has been stopped, if there's been progression of more than half a diopter, then they should reintroduce atropine. If not, then again, the approach is to try and move them to an appropriate treatment strategy. So, Jose, in terms of follow-up for young myopes, what do you think is optimum? How frequently do you think they should be followed up?
Well, follow-up is for sure a very important point in myopia control. As said, it's applied to young myopes during progression. So those should be followed closely because their refractive error is changing and should be closely monitored and the refractive error adjusted to ensure permanent optimal prescription, which is important for visual quality and visual efficiency as well as to prevent further progression. These changes can be as rapid as 3 to 6 months, so the current advice is that initially these patients should be monitored every 3 months to assess progression and later at least every 6 months. Younger children showing rapid progression might require closer follow-up to detect refractive changes. As myopia progresses more slowly later in life, a visit every 12 months might be sufficient. This is indeed the recommendation of the International Myopia Institute Clinical Management Guidelines. Treatments with more potential for side effects, such as pharmacological treatments or contact lenses, might justify closer follow-up to detect potential adverse events.
Jose, I think the evidence is quite clear. We can reduce the risk of onset of myopia as well as slow the progression of myopia in eyes that are already myopic. The biggest bang for our buck is to try and delay the onset of myopia. Even if we are able to delay the onset of myopia by 1 year, especially in young children, that's quite a substantial impact that we can make in terms of the burden of myopia and trying to reduce the burden of myopia. In terms of delaying the progression of myopia, again, similarly, we gain a lot more if we can treat that young myope, catch that young myope early and treat them with the appropriate intervention strategy right at the onset, because again, that is going to give us a lot of gains in terms of trying to reduce the burden of myopia. I think that's about it.
Thank you. Welcome.